different aspects of NTG management. So the first one is a case of a 70-year-old gentleman who presented for a routine eye screening with the intraocular pressure of 16 and 18 millimeters of mercury in the right and the left eye, an open angle by gonioscopy. The right eye disc was about 0.8 with bipolar thinning, and the left was again 0.8 bipolar with more of inferior rim changes. The perimetry showed corresponding biarcuate defects, and of the right eye, and the left eye showed superior arcuate changes. So investigating further, they had average corneal thickness. The diagonal variation test did not go beyond 20. So with this, we made a provisional diagnosis of normotensive glaucoma in both the eyes and started the patient on prostaglandin analogs. Revisiting the NTG history, he gave a positive family history of glaucoma. He was a diabetic, and also a history of occasional micturition syncope. So in this slide, we kind of assess the vascular factors. The ocular perfusion pressure was assessed in different postures, and we found that it was significantly less. In the right eye, fluctuating between 40 and 46 millimeters of mercury. In the left eye, between 39 and 45 millimeters of mercury. So various studies, landmark studies like Rotterdam and Barbados, have highlighted the significance of ocular perfusion pressure in open-angle glaucoma. To throw further light into the vascular factor, we also did a color Doppler imaging. So we found that the resistive index was found to be significantly higher in both the right and the left eye, going between 0.69 to 0.8 in the right eye and between 0.75 and 0.79 in the left eye, which kind of concurred with the Western literature, where they showed an association of NTG with a resistive index of about 0.8. So the vascular pathomechanism is well established as far as NTG is concerned. Following this patient up in December 2022, the right eye was fairly stable on 3 AGM, and the left eye, though the trend looked fairly stable, there was progression in the event analysis, which was also seen in the 10-2. We advised trabeculectomy and cataract extraction, and 4 months since he's been stable. So this is a regular NTG presentation. So going on to the second case is that of a 34-year-old gentleman who presented with a low baseline intraocular pressure of only about 12 millimeters of mercury, and what was striking was the asymmetry in the cup disc ratio. So the left eye, there was a superior notch, and the only positive history was dyslipidemia. So considering the asymmetry in the glaucoma presentation and the low baseline intraocular pressure, we also got a neuroimaging done, which was fairly normal. This was the right eye perimetry. The left eye showed rapid progression. This was the picture 2 years later. So because of the history of dyslipidemia, we did a carotid Doppler, which showed a circumferential plaque of the left carotid artery bifurcation. Case 3 is a symmetrical cupping with inferior rim changes. So she also had a baseline intraocular pressure of only 10 millimeters of mercury. So again here, what is striking is a symmetry in both the structural and the functional tests. So the question, and she was absolutely symptom free, though the central field was markedly involved, there was no visual symptoms whatsoever. So in the light of the above said findings, the question is whether we were dealing with an anomalous disc. So talking about case 4, this was a recently seen patient who was treated as NTG outside. However, there was a marked asymmetry between the disc parameters and the visual field changes. Got 10-2 done for this patient, and what we see is a ring scotoma. So while asked for a positive history, he did say he had difficulty in dark adaptation, and he was referred for a retinal clinic opinion where he showed reduced scotopic responses in both the eyes, and he was concluded to have cone rod dystrophy. So the other important differential to consider would be neurological causes, where the cue would be paramorine cupping, fields respecting the vertical meridian, and the disc not correlating with the fields. Other add-ons to NTG diagnostic toolkit would be a detailed sleep apnea workup, OCTA, neuroimaging, coagulation profile, and nutritional deficiency assessment. The stop band clinical assessment score can be done to assess the severity of OSA. Again, the role of OSA in NTG has been well proven. So that my take-home message is detailed history taking and extensive workup is required to rule out IOP independent factors and other differential diagnosis. However, we do continue to manage them like any other open-angle glaucoma, where IOP is still relevant as proven by CN-GTS study. NTG also remains an enigma. Much to be known and researched as far as NTG is concerned.
Thank you, Nagalekshmi, for wonderful collections of NTG. You are 34 years patient. Did you treat that patient? The cause was carotid.
Yes, ma'am. We did put him on anti-glaucoma medication as well, because it was riskier to wait with such a rapid rate of progression. Though we did address that aspect by starting him on antiplatelets as well.
Analyst, it's good to treat at 34 years because the age was very important.
Anything about the CSF pressure?
Not really, sir. We didn't do it.
That's one thing that I would like to comment about the USA part, because we just published an article, it just come out in Journal of Glaucoma. So one needs to be very careful and we need to rule out USA, because sometimes we have some patients, your target pressures are not being achieved with your adequate medication, and those are the patients you should look at the ocular perfusion pressures and the OSA, because we found even with the normal subset around 90 patients of OSA, the severe cases of OSA, they had pressures in the range of 17, 18, 19 millimeters of mercury, and RNFLs were in the range of around 80 microns, which is actually on the thinner side. So you need to be very careful about OSA also.
So, in your patients, once you titrated the OSA, did the intraocular pressure reduce? Once you do the CPAP, what I have noticed is if you put them on CPAP, see them about 2 weeks, 4 weeks later, the intraocular pressure starts coming down.
So again, there are two views on that. Some people say that using CPAP, the IOP might go down. There is another thought which says using CPAP, the IOP may actually go up. So it's still controversial.
You did CPAP. You use the CPAP.
So we did. नहीं CPAP के बाद ही लेगा, CPAP के बाद वो नहीं लेगा.
That will be the next paper. We also published one on again. Yeah.
बट उसमें कहते हैं कि कुछ कहते हैं कि बढ़ भी जाता है, कुछ कहते हैं कम हो जाता है.
See, OSA patient, whether we should treat or not.
The patient I am talking about had got triple combined procedure in both the eyes, one tube implant, and on 3 medication. After titration with CPAP, pressure was hovering around 20, 19, 20. After titrating, it became like 10, 11, 12. So I was shocked. He was also very happy. I gave him ambulatory BP monitoring, this, that, everything. He said everything's fine. Just did CPAP, did titration. His AHI level improved. His IOP dropped. I was able to reduce one by one medication I have to wean off. They don't have to use it every day. He uses it only 3 times a week. Every day it's very cumbersome.
People who do use the CPAP become very used to it, and they won't even go. They won't ever go even 1 day without it. So if it can help somebody, I think we just need to follow up with these patients and see as to how they do. नहीं होती. आजकल they have very good masks which are just around the thing and it doesn't.
Exactly.
I live with a person who does. My husband doesn't.
And even after patient use it, it doesn't happen. It doesn't come with the low or anything.
There's more incidence of cardiac events, so if they use it, it is always better.
And I had a question, yes, Ganga, what would be your first line of treatment for NTG? Because for your patient, the first case, you had put the patient on
prostaglandin. So the first patient, the patient had a high pressure. I mean, his pressures were in the higher teens. And he already had a family history, one more risk factor. So I thought the target pressure should be, at least 30% lesser. So in maybe a suspect kind of case or early glaucoma, maybe a brimonidine might have been a better choice.
Another thing, you talked of the resistive index.
Yes, ma'am.
And amongst the different patients, if you go back to that slide,
yes,
it was the ophthalmic artery which they had it higher.
Yes,
the others were not. But actually, they say it's the it's the lateral ones and not even the CRA which is important.
Yes, ma'am.
So whenever we do it for 4 vessels. the ophthalmic artery, the central artery, and the lateral and medial arteries.
Yeah, that particular case actually, because there was a history of syncope, we wanted to evaluate on the vascular aspect as well. So as you rightly pointed out, it was more of the ophthalmic artery which showed a higher side of
which does not actually have so much of a role
clinical
to play in the
significance. Yes.
ocular profile.